Good afternoon. This is Danielle Chalminsky from the Integrated Care Resource Center, or ICRC. Thank you all for joining us today for this Working with Medicare 201 webinar, which is part of ICRC's training curriculum developed to assist states in better working with Medicare. Next slide, please. So before we get started, I'd like to quickly go over a few logistics. For those of you joining by phone, you can view the slides by logging into Zoom. You can find those directions in the appointment for today's webinar. To eliminate background noise, phone lines are being muted during today's presentation. You can submit questions via Zoom at any point during the webinar by using the Q&A icon at the bottom of your screen. There will be no unmuting of phone lines at the end of the presentation for Q&A, but we encourage you to use the Q&A window since our presenters are eager to answer your questions. If you include your email address and we don't get a chance to answer your question on today's webinar, we can follow up with you afterwards. And as usual, we will be recording this call so you can revisit today's presentation or share the recording with colleagues who are unable to join. Next slide. So during today's webinar, we will provide an overview of Medicare program features of interest. Today's webinar is part 2 of the 101 and 201 Working with Medicare webinar series. Monday's Medicare 101 webinar and the slides are now live on the ICRC website in case you missed it or would like to watch it again. Other annual webinars of interest in this series are an update on state contracting with DSNPs, Medicare and Medicaid nursing facility benefits, and coordination of Medicare and Medicaid behavioral health benefits. And as you leave the webinar today, we have a short evaluation to gather feedback about this webinar and the Working with Medicare webinar series as a whole. We hope that you take the time to complete this survey. It will also be sent out with the recording and the slides from today's webinar in an email after the webinar. Next slide. So before we get started in today's 201 webinar, I want to give a quick recap of what we covered in the 101 webinar earlier in the week. First, we went over some basics on dually eligible individuals. Dually eligible individuals have both Medicare and Medicaid and often have both complex care needs and high costs of care. Because of this, this group has been particularly and disproportionately affected by the COVID-19 pandemic. And states can use integrated care programs to coordinate Medicare and Medicaid benefits, improve care, and streamline materials and processes for dually eligible individuals, which is what we'll be talking about today in more detail. Next slide. Next, we gave a brief introduction to Medicare. Medicare is a federal health insurance program that covers a variety of services. All Medicare beneficiaries, including dually eligible individuals, can choose to receive their Medicare benefits through Medicare Advantage managed care plans, and enrollment in these plans has grown over time. Also, Medicare Advantage plans can offer supplemental benefits as well, which we'll also be discussing today. Next slide. Lastly, we discussed the roles of Medicare and Medicaid when serving dually eligible individuals. Medicare is often the primary payer for services a dually eligible individual may need, but there are some core coverage gaps for which Medicaid pays for dually eligible individuals. Medicare covers most primary and acute care services, while Medicaid covers long-term services and supports, and Medicare and Medicaid coverage duplicate for a number of service types. Finally, Medicaid supports dually eligible individuals by covering Medicare Part A and/or B premiums and cost sharing. Next slide. So during today's webinar, we'll go a bit further into some details on ways that states can better integrate care for dually eligible individuals. This includes developing and implementing integrated models, working with DSNPs around supplemental benefits, and actions that states can take to improve quality of coordination for dually eligible individuals. Now, we know that not everyone in Medicaid agencies are dealing with all of these issues, but these are important issues that set a foundation for effective coverage of dually eligible individuals and integration of services. We will be getting into the details of these strategies today, and we realize that some of these strategies are a bit complex and nuanced. Therefore, ICRC is available to any state that is interested in learning more about these strategies. And ICRC has a number of written tools on all of these topics that are listed throughout the presentation, in the appendix slides, and on our website. Today, we aim to expose you to these issues, and we're happy to work with you and other members of your staff after the webinar to help you navigate the specific issues that you're facing in your individual states. Next slide. So today's webinar will feature two ICRC staff, Caitlin Murray and Giselle Toralba. And now I'll hand it over to Caitlin to begin the presentation.
Thanks, Danielle. All right, so my name is Caitlin Murray, and I'm going to be talking about the different ways in which states can integrate care for duly eligible beneficiaries. And then later, we're going to talk about how states can work with D-SNPs to design supplemental benefit offerings. Next slide, please. All right, so a lot of the information in this section is based on an ICRC technical assistance tool called the State Pathways to Integrated Care. And this is a fantastic tool for states that are interested in learning just a little bit more about what integrated care approaches would work best for them. It's interactive, it takes you through the process step by step, and it just contains a whole lot of detail that we don't have the time to get into today. So I encourage anyone who's interested to check it out. This graphic right here basically just shows the roadmap of going through, the initial considerations of who is your duly eligible beneficiary population, what are their needs, what is the current environment in which they receive care, and what are the potential opportunities that that environment presents for integration. To kind of the next step of addressing foundational issues such as how to leverage Medicare data to improve integration, or executing Part A buy-in agreements, to kind of the final step here of choosing which is the best integrated care model to fit your state and advances your policy goals. And you have a few options here. So we have capitated managed care, managed fee-for-service, and state-specific models. Next slide, please. Okay, so let's dive into those three options just a bit more. So capitated managed care is when the state and/or federal government pays capitated rates to managed care entities that deliver and coordinate Medicare and/or Medicaid services. And this can take many forms, including MMPs, managed long-term services and supports, D-SNPs, and PACE. Managed fee-for-service occurs when benefits are paid through a fee-for-service arrangement, but care coordination is provided to help beneficiaries better navigate their care. And this can also take a few forms, including FAI demos, Medicaid health homes, and PCCM. And the third option we have here is for states to develop and test their own innovative models. Next step, please, or next slide, please. Okay, so we're going to dive deeper into all those three options we just talked about, but we're going to be spending the most time talking about capitated managed care, since that is the predominant path that most states take towards integration. So as you now know, there are a few different forms of capitated managed care, and we're going to talk a little bit more about each of them. So PACE is a program in which organizations provide integrated Medicare and Medicaid covered services for people who are 55 and older who are at the nursing home level of care. And these services include primary, acute, specialty, and LTSS, and the organizations that provide them are paid through capitated rates. MMPs are three-way contracts between the state, CMS, and health plans that enable delivery of integrated behavioral health, primary, LTSS, and acute care for duly eligible beneficiaries. And MMPs receive capitated blend payments. Next slide, please. So D-SNPs are Medicare Advantage plans for duly eligible beneficiaries that must coordinate Medicare and Medicaid benefits at a minimum. D-SNPs are required to hold a contract with the state Medicaid agency, and they must include certain minimum requirements that determine the level of administrative, clinical, and financial integration. D-SNPs do have the option of pairing with either affiliated Medicaid managed care or MLTSS plans. And there are three different types of D-SNPs, which range from coordination only, which is kind of the least integrated option, to HIDE and SIDE SNPs, which are relatively more integrated. Next slide, please. So this table here just highlights some of the key differences between these capitated managed care programs. And I'm not going to go into every data point here, but this is just to highlight that there is a lot of variation just in the number of states in which these programs are available, the number of plans, the enrollment numbers, and the ways in which each are administered. So, PACE compared to the others, relatively small in terms of total enrollment, but it is in quite a number of states. MMPs here, they're different from other states in that they're authorized under a demo. And then coordination-only DSNPs have the highest enrollment, highest number of plans, and the most states in which they operate. Next slide, please. So this slide is here just to help you visualize how all these integrated, all these capitated managed care pieces fit together. And the green boxes represent the integrated programs, whereas the white are not integrated. So you can see that DSNPs are a type of Medicare Advantage plan that may cover Medicaid acute care, managed long-term service and supports, and behavioral health. And then you can also see here the two subsets of DSNPs, which are FIDE and HIDE. Okay, next slide, please. All right, so this slide just shows the capitated managed care models in terms of their level of integration. It goes from the least integrated on the left to the most integrated on the right. So let's start at the left. Fee-for-service Medicare and Medicaid provide inpatient, outpatient, and prescription benefits all separately, and Medicaid benefits are provided through fee-for-service or Medicaid managed care plan. Next, we have regular Medicare Advantage that provides all Medicare benefits under one plan, but Medicaid benefits are entirely separate. Next is the DSNP model, where all Medicare benefits are covered by the DSNP, and Medicaid benefits may be covered, but at the very least are coordinated by the DSNP. There is a lot of variation in DSNP. Some, kind of only provide the bare minimum of coordination of Medicaid benefits, and then some, cover all Medicaid benefits. There are FIDE and HIDE next, which, in addition to covering all Medicare benefits, must provide at least some coverage of some Medicaid benefits, including coverage of LTSS and or behavioral health. Next, we have MNPs, which operate in state demos under a financial alignment initiative. MNPs are even more integrated than FIDE and HIDE because they're just one plan that covers all Medicare and Medicaid benefits. And then PACE here at the end also covers all Medicare and Medicaid benefits under a single entity, but as we said before, it's only available to individuals who are at the nursing home level of care. Next slide, please. So DSNP contracts can have aligned enrollment or exclusively aligned enrollment. So let's talk about that. What does that mean? When we talk about aligned enrollment, we mean enrollment in a DSNP and a Medicaid managed care plan that are offered by the same parent company in the same geographic area. And when we talk about exclusively aligned enrollment, we're talking about cases where the state contractually obligates DSNPs to limit enrollment to full benefit dually eligible individuals who receive Medicaid benefits from either the DSNP or an affiliated Medicaid managed care plan offered by the same parent company as the DSNP. So, the benefit of exclusively aligned enrollment is that it creates opportunities for integrated delivery of Medicare and Medicaid services by, aligning incentives and coordinating benefits administration, streamlining payment of Medicare cost sharing, facilitating care coordination, and allowing integration of beneficiary materials. Next slide, please. So as of the start of this year, DSNPs must meet at least one of the following criteria. They either need to cover Medicaid behavioral health and or LTSS in order to be designated as either a FIDE or a HIDE SNP, or they have to notify the state and or its designees of Medicare hospital and skilled nursing facility admissions for one group of high-risk enrollees, the goal of which is just to improve coordination during transitions of care. There is also a new requirement that FIDE and HIDE SNPs with exclusively aligned enrollment must have integrated appeal and grievance processes. And for those who are interested in learning a little bit more about that, we have a link here for additional information. And there's also a really great fact sheet on this on the ICRC website. While these requirements are on the DSNPs, we should say that, and they're not on the states themselves, we should say that, states do have the flexibility to decide how they want their DSNPs to meet these requirements. And they do have the opportunity to work with their DSNPs before the July 5th submission deadline, if they so choose. And we have a lot of great resources listed in the appendix to help guide you through that process. Next slide, please. All right, so this chart gives you just a sense for how many full benefit dually eligible beneficiaries are enrolled in capitated managed care. So you can see that overall, about 34% are enrolled in capitated managed care, whereas about 66% are enrolled in other Medicare Advantage plans or fee-for-service Medicare. So, in other words, about 1/3 of dually eligible individuals are enrolled in some form of integrated care, which, means there is some room for growth here. DSNP programs enrolled the most dually eligible beneficiaries at about 30%. And when you break that down by type, coordination-only DSNPs accounted for the largest share at 16%. HIDE SNPs had about 12%, and FIDE SNPs had about 2%. About 4% of dually eligible beneficiaries are enrolled in MMPs. And then PACE here is the smallest program if you go by enrollment at less than 1%. But again, that may just be partially a function of the eligibility requirements. Next slide, please. All right, so to close out the section on capitated managed care, we just wanted to give you a bigger picture of what the capitated managed care landscape is looking like. So this map shows what states have integrated DSNPs, including HIDE and FIDE SNPs, financial alignment demos, or both as of this year. Next slide, please. So one of the other paths to integration that we talked about at the top of this section is managed fee-for-service. Now, there are several types of managed fee-for-service. The first is that under the Financial Alignment Initiative, there is a type of demonstration that is a managed fee-for-service model that covers all the same services, just under a different payment structure. The second is that states have the option to develop what are called primary care case management, or PCCM, that provide Medicaid benefits with care management. And the last type of managed fee-for-service is Medicaid health homes, which are specifically for Medicaid beneficiaries with chronic physical or behavioral health conditions. Next slide, please. Okay, so we cover the two main existing integrated care programs, which are capitated managed care and managed fee-for-service, but states also have the option to create their own state-specific models to better serve dually eligible beneficiaries. So at the top of this slide, we've included a state Medicaid director letter put out by CMS in 2018, which just includes 10 opportunities that states could take advantage of without having any demonstration authority or Medicare waiver. And the second resources that we've included here is a 2019 letter from CMS. CMS is open to partnering with states to test new state-developed models to better serve dually eligible beneficiaries. And these models can have elements of other existing models, or they can be something entirely new that just promotes integration and better overall care. Next slide, please. All right, so that brings us to the next section, which is on how states can work with DSNPs to design supplemental benefit offerings. Next slide, please. So DSNPs and all Medicare Advantage plans can offer supplemental benefits to members. And the great thing about supplemental benefits is that you can really leverage them to extend and expand existing Medicaid coverage for dually eligible beneficiaries. So traditionally, supplemental benefits are kind of confined to being health-related, but the rules have been more relaxed more recently to broaden these benefits to include items that are related to LTSS and social risk factors. And the three main ways in which these benefits have been broadened are through the expansion of primarily health-related benefits, which gives plans more room to cover services that address LTSS needs, newly established special supplemental benefits for the chronically ill, or SSBCI, which are designed to address needs stemming from social determinants of health for those with chronic conditions, and the relaxation of the uniformity requirement, allowing Medicare Advantage plans to target these benefits to an individual and really specific medical conditions and needs. Next slide, please. Okay, so to just make this a little bit more concrete, we've included some examples here of what these supplemental benefit types might look like. So, some examples of standard primarily health-related benefits are hearing, vision, and dental. Examples of the newly expanded benefits that are available to anyone in the plan can include support for caregivers, adult day health, and bathroom safety devices. And examples of SSBCI can include structural home modifications, respite, and delivering groceries. Next slide, please. Okay, so we've laid out some opportunities for states to coordinate with DSNPs on supplemental benefit offerings here. And the first opportunity is through filling gaps in existing Medicaid coverage. So depending on the state, Medicaid programs may be more or less generous in the amount or type of benefits covered, or they may experience periodic cuts to services due to budget constraints or other forces. So supplemental benefits can help to make up for some of those limitations. Supplemental benefits can also be leveraged to overcome barriers in accessing Medicaid HCBS. In some states, restrictive eligibility criteria or waiting lists may prevent some dually eligible individuals from accessing Medicaid HCBS. And supplemental benefits can support individuals who maybe don't quite meet the institutional level of care criteria, but they do have some degree of functional decline. Another opportunity is using supplemental benefits to address social needs. So in particular, the new SSBCI can be leveraged to address member needs related to social determinants of health, such as providing home pest control or non-medical transportation, and can be used to enhance supports for family caregivers. The last opportunity here is reducing avoidable costs. There is the potential that supplemental benefits can reduce costs to members, state Medicaid programs, and plans. So, for example, supplemental benefits can provide preventative care that reduces hospitalization and ER visits, and they can also prevent or delay the use of Medicaid LTSS benefits. Next slide, please. So there are some important considerations for states regarding DSNP supplemental benefits that are worth mentioning. There cannot be any duplication between the supplemental benefits and existing Medicaid benefits offered to dually eligible individuals. However, DSNPs can offer supplemental benefits for optional services that are also covered by Medicaid, like dental or vision services, as long as the supplemental benefits expand and do not duplicate what's covered by Medicaid. There are limitations on supplemental benefit offerings, both in terms of the types of services that can be covered and in the individuals who are eligible to receive them. So, for example, the SSBCI is only available to individuals with chronic conditions. The amount of the rebate dollars a DSNP receives can vary, and it will depend on factors like a plan's star rating and year-over-year changes. And just to give you a sense of scope, in 2021, the average rebate amount was $140 per enrollee per month. And it's important to consider, what is the value add to the plan in offering a certain supplemental benefit? Does the benefit improve quality of care? Does it improve outcome? Is there a return on investment? And it may also just depend on what other plans in the market are offering. Next slide, please. Okay, so to see what all this looks like in action, we've pulled together a few examples of current state requirements for DSNP supplemental benefits. In Arizona, plans have the flexibility to design benefit packages that are responsive to their local community and market. And they're also encouraged to propose innovative supplemental benefits. In Minnesota, there are annual meetings between the DSNPs and the state to talk through supplemental benefits and how they fit into the plan's larger benefit package. DSNPs are also required to submit data to the state's actuary just to ensure that benefits are being billed correctly. And in Pennsylvania, DSNPs must offer at least one supplemental benefit that fills a gap in Medicaid services that full benefit dually eligible individuals are eligible for. DSNPs are also required to submit a list of their supplemental benefits to the state, and there are quarterly meetings between the plans and the state to discuss benefit offerings, among other things. Next slide, please. Okay, so let's talk about the potential challenges to state oversight. So, we talked about how supplemental benefits cannot be duplicative of existing Medicaid benefits. So one solution here is for states to create an ongoing dialogue with DSNPs about benefit design, which can be done through regular quarterly or semi-annual meetings. States also have the opportunity to coordinate with DSNPs before the plans submit their bids to CMS. Another challenge is that there is potential for inappropriate billing between Medicare and Medicaid. And states that are looking to avoid this may want to consider, their oversight options, which it could range from an approach similar to Arizona of having the DSNP track their own utilization and supplemental benefits, or it could be a more active, hands-on oversight role requiring DSNP to submit data for the state for review. The last challenge is in the marketing of these benefits to duly eligible individuals. And the way that DSNP describes supplemental benefits in their marketing materials may cause confusion for duly eligible individuals, especially for certain benefits like SSBCI, where there may only be a certain subset of individuals that are actually eligible for that benefit. And one way to get around that is for states to monitor how DSNP marketing materials describe coverage of supplemental benefits like vision, dental, and hearing services that may be covered under the state's Medicaid program. Next slide, please. So in terms of next steps, states may want to look at how state Medicaid benefits, capitation payments, and/or cost-sharing policies for duly eligible beneficiaries would intersect with supplemental benefits offered by DSNP. They may also want to determine if there are FIDE, HIDE, or DSNPs in the state that offer companion Medicaid products. They can create a space for dialogue with the DSNP to better facilitate coordination. States can share data to foster collaboration, and they can add language to the DSNP SMAC that requires them to work in collaboration with the state in developing supplemental benefits. So the great news here is that we are now in the window of opportunity for states and DSNP to start engaging on supplemental benefits and to see how they may complement existing Medicaid benefit offerings, since DSNP must include details on Medicare supplemental benefits for calendar year 2022 in their upcoming bids to CMS, which are due on June 7th. Next slide, please. All right, so with all that said, thank you for listening, and I am now going to turn it over to Giselle.
Thank you so much, Caitlin. Hi, everyone. Again, my name is Giselle, and I will be going over some actions that states can take to improve the quality and coordination of care for duly eligible individuals. Next slide, please. So first up is increasing the frequency of data exchange with CMS. But before we dig into that a little bit more, it might be helpful to just first provide a brief overview of the specific data that we're talking about here. The first are Medicare Modernization Act files, or MMA files. States exchange these files with CMS to identify all full benefit and partial benefit duly eligible individuals in each state, as well as prospective duly eligible individuals who are people who will become duly eligible in the next 3 months. The second are buy-in files, which identify duly eligible individuals whom the state is liable for Parts A and B premiums. Both of these files can be exchanged with CMS as frequently as daily and as infrequently as monthly. So when states submit these files to CMS, CMS will send back response files, and states can match that response file with their own state data to ensure accurate records. States can also use the MMA response files to identify people becoming duly eligible for the purposes of enrolling those individuals into integrated care programs, like Federal Alignment Initiative demonstrations, or into DSNPs using a process known as default enrollment. And states can use buy-in files to also understand the costs of their Medicare Part A and B premium liability. Next slide, please. Despite the current variance in file exchange frequency across states, starting April 1st, 2022, all states will be required to exchange both MMA and buy-in files with CMS daily per the interoperability and patient access final rule. We've included a high-level summary of the status of state file exchanges on this slide, but definitely refer to the ICRC resource linked at the bottom to see where each state stands and to get some more information about this new rule and the benefits of daily file exchange. It's also important to note that although the exchange provisions will take effect on April 1st, 2022, states can begin transitioning to daily exchange at any time before then. Next slide, please. So with regard to exchanging MMA files, doing so more frequently can provide several benefits for beneficiaries, the state, and providers. First, more frequent MMA file exchange can improve beneficiary access to care by facilitating faster access to Medicare subsidies and more efficient communication about benefits. For qualified Medicare beneficiaries specifically, or QMBs, it can result in quicker coverage of Medicare cost sharing, faster communication regarding their lack of liability for Part A and B cost sharing, and protections from providers who try to bill them inappropriately for Medicare cost sharing amounts. And just to clarify, QMBs are a category of dually eligible individuals who receive coverage for Medicare Part A and B premiums, as well as coverage for Part A and B cost sharing through the state Medicaid program. More frequent MMA file exchange can also help drive state efficiencies, including earlier enrollment of dually eligible individuals into integrated products and faster transitions of individuals into Medicare as the primary payer for services. It also provides a method for streamlining error identification and resolution should anything ever come up. And finally, for providers, a major benefit of frequent file exchange is that it lessens their administrative burden and reduces the likelihood of dealing with payment inaccuracies and recoupments because beneficiaries are transitioned into Medicare coverage more quickly. In other words, more frequent file exchange significantly reduces the likelihood that a provider would bill Medicaid for something for which they should ultimately be billing Medicare, and therefore reduces the need for providers and the state to reconcile and recoup those payments later. Next slide, please. So just as a reminder, buy-in files identify individuals for whom the state is liable for paying Part A and B premiums. Like with MMA files, exchanging buy-in files more frequently can promote more timely access to coverage and lessen the burden on the state and beneficiaries. For example, more frequent buy-in file exchange enables quicker beneficiary access to Part A and B services because states and CMS can identify and remedy buy-in coverage errors more quickly, which can then help facilitate Medicare enrollment and a faster shift to Medicare as the primary payer. It also facilitates beneficiary enrollment into integrated care plans, which has implications for improved care coordination and management of Medicare and Medicaid services. Frequent buy-in file exchange also helps avoid inappropriate out-of-pocket costs for beneficiaries by stopping Medicare premium deductions more quickly, leaving low-income dually eligible individuals with more money to meet their other needs like housing and food. For more information on the benefits of more frequent MMA and buy-in file exchange with CMS, review the ICRC Technical Assistance Brief linked at the bottom of this slide. Next slide, please. Another action that states can take to improve quality and coordination of care for dually eligible individuals is enter into a Part A buy-in agreement with CMS. Part A buy-in agreements permit states to directly enroll QMB eligible individuals into Part A at any time of the year without late enrollment penalties, because the state is responsible for paying Part A premiums for these individuals. The avoidance of late enrollment penalties results in direct cost avoidance for the state. Additionally, Part A buy-in agreements simplify the Part A enrollment process for dually eligible individuals, which establishes Medicare as the primary payer for inpatient and outpatient care, as well as prescription drugs through Part D. Next slide, please. So another thing that states can do is simplify Medicare Savings Program eligibility and enrollment. But first, some level setting. MSPs are Medicaid programs that cover Medicare premiums and in some cases cost sharing for dually eligible individuals. Through MSPs, Medicaid may pay for some or all of the Medicare premiums and cost sharing for low-income Medicare beneficiaries. Premium and cost sharing coverage varies depending on which MSP an individual qualifies for. The Medicare Part D Low-Income Subsidy Program is a federal program that assists with the costs of Medicare Part D plan premiums, deductibles, coinsurance, and co-payments for low-income beneficiaries. All dually eligible individuals qualify for LIS and therefore receive assistance with their Medicare prescription drug costs. So while MSPs and LIS both provide assistance to low-income beneficiaries with Medicare costs, the LIS program has a much higher participation rate than MSPs tend to have, though MSP participation rates do vary by state. Aligning MSP eligibility criteria with those used for the Medicare Part D LIS program can streamline enrollment into MSP benefits because it enables states to maximize use of Social Security Administration LIS leads data to initiate MSP applications. So when beneficiaries apply for Medicare Part D LIS through the Social Security Administration, federal law requires that the administration transfer leads data from LIS applications to the state agency, which the state can then use to trigger an MSP application. The leads data files contain a helpful host of information, including whether the beneficiaries are eligible for full or partial LIS benefits, as well as demographic, income, and asset information. This data can be used at the state level to facilitate enrollment into MSP benefits through a few different ways. First, states can use it to automate MSP enrollment for eligible beneficiaries. Second, the SSA leads data can also be used to identify individuals whose MSP eligibility should be reviewed. Then the state can use state data to verify that eligibility. Third, states can use the data to pre-populate MSP applications and mail them to beneficiaries who appear to be eligible. Or finally, states can use the data to conduct other types of mail or telephonic outreach to assist beneficiaries with their MSP applications. For more information about aligning MSP eligibility criteria with LIS, see the ICRC tip sheet listed as the source at the very bottom of the slide. Next slide, please. So moving on to strategies related to coverage of Medicare cost sharing. So all states are required to cover Medicare cost sharing for certain categories of dually eligible individuals, but state policies for Medicaid coverage of Medicare cost sharing do vary. Typically, Medicare is the primary payer for the majority of services utilized by dually eligible individuals. So providers must usually bill Medicare first. After Medicare is billed, claims then must be crossed over to Medicaid for services that Medicare doesn't cover, but that Medicaid might. We're going to talk a little more about cost sharing on the next couple of slides, but for a deeper dive into state coverage of Medicare cost sharing, see the resources at the bottom of the slide. Next slide, please. So there are some variations in how states cover Medicare cost sharing. States can either cover the full amount of the Medicare deductibles or coinsurance, or choose to pay the lesser of amounts. The lesser of policy allows the state Medicaid programs to pay less than the full Medicare cost sharing amount if the Medicare rate for the service exceeds the Medicaid rate. So Medicaid will pay the lesser of the full Medicare cost sharing amount of deductibles and coinsurance, or the difference between the Medicaid rate and the amount already paid by Medicare. So this amount is zero in cases where Medicaid's rate is lower than Medicare's payment. States that have actually adopted the lesser of rate often end up eliminating or completely reducing Medicare cost sharing payments to providers. Next slide, please. So when Medicaid doesn't cover cost sharing up to the full Medicare approved amount, meaning that the state is using a lesser of payment policy, QMBs cannot be billed for the balance, which means that the difference has to be absorbed by providers. This can then lead to access to care issues if providers are reluctant to treat those beneficiaries. So that was just a brief overview. We've provided a couple of resources on this slide that dig a little bit deeper and about preventing providers from improperly billing QMBs for cost sharing amounts that they don't owe, as well as a resource about access to care issues that can arise among QMBs, particularly when states use lesser of payment policies. Next slide, please. So these next two slides will cover ways that states can streamline the administrative process involved in coverage of Medicare cost sharing. First, we'll discuss crossover claims processes. As I noted previously, when Medicare is the primary payer, Medicare usually pays first, and then the state must cover any cost sharing owed for QMBs or other beneficiaries who may qualify for state coverage of Medicare cost sharing. To transfer provider claims from fee-for-service Medicare to fee-for-service Medicaid, states and the federal government use what are known as crossover claims processes. But when managed care plans are involved in covering Medicare and or Medicaid benefits, sometimes providers have to submit two separate claims to Medicare and Medicaid, which can then be confusing and burdensome for providers, plans, and the states. When dual eligible special needs plans, or DSNPs, cover Medicare benefits for at least some dually eligible individuals in a state, states can set up automated crossover claims processes between those DSNPs and the state to reduce burden on the providers, beneficiaries, and payers. Automating the crossover claims process makes the billing process easier for providers who can simply submit one claim for payment, which is then automatically crossed over from the DSNP to the state or the Medicaid managed care plan for Medicaid coverage. For beneficiaries, this can make it less likely that they experience improper billing or be denied access to care. And for states and plans, they'll no longer have to use manual processes to identify claims for which the state or the Medicaid MCO owe payment. Finally, an important call out to note is a recent change in the 2020 Medicaid managed care final rule, which no longer requires states to use automated crossover claims processes with their Medicaid managed care plans. States are now allowed to choose whether to establish automated processes or use an alternate method for coverage of crossover claims. However, for the reasons noted on the slide, automatic crossover claims processes can be particularly beneficial when a state is simultaneously working with DSNPs and Medicaid managed care plans to cover care for dually eligible individuals. Next slide, please. So another strategy to streamline coverage of Medicare cost sharing is capitating managed care plans to cover the cost sharing. If a state contracts with a DSNP for coverage of Medicare cost sharing, for example, then the DSNP will become solely responsible for both the Medicare and Medicaid portion of provider payments. Having the DSNP responsible for Medicare and Medicaid payments can help to streamline the payment process for providers and reduce improper billing of beneficiaries caused by the need to separately bill the DSNP for coverage of Medicare benefits and the state or Medicaid MCO for coverage of Medicare cost sharing, and the uncertainty whether the enrollee, the state, or the DSNP is responsible for payment of cost sharing. It also enables DSNPs to negotiate rates with high-value providers that may increase access to care for DSNP enrollees, particularly in states that use a lesser of policy. Capitating plans to cover cost sharing can also enable DSNP's network providers to receive the same cost-sharing payment from the DSNP, regardless of whether they are enrolled as Medicaid providers. This can improve access to care for enrollees who might otherwise have difficulty finding providers who accept Medicaid payment. Next slide, please. So that is the end of the section covering actions that states can take to improve the quality and coordination of care for dually eligible individuals. A quick summary and some key takeaways that we want to leave you with regarding some of these actions are that states can increase the frequency of MMA and buy and file exchange with CMS to support more timely access to coverage and reduce burden for states, beneficiaries, and providers. States can also enter into a Part A buy-in agreement with CMS to streamline enrollment, eliminate enrollment penalties, and establish Medicare as a primary payer for certain services. They can also simplify MSP eligibility and enrollment by aligning with LIS, using SSA leads data, and streamlining redetermination processes. And finally, states can streamline coverage of Medicare cost sharing with automated crossover claim processes, or by capitating DSNPs or managed care plans to cover cost sharing for enrollees. So like Danielle mentioned earlier, these strategies that we presented are very complex and very nuanced. And the point of introducing these concepts to you today is just to provide some initial foundation and grounding in these topics. If you're interested in learning more, ICRC is available and happy to provide assistance and answer any questions that you might have. I will now turn things back over to Danielle.
Great. Thank you so much, Giselle. So now I'd like to invite any questions for our panelists. And again, if you have a question, please click on the Q&A icon and just type it in. We also have other ICRC colleagues on the line. We have Erin Ware-Lochmani, Jim Verdier, and Nancy Archibald, who are also available to answer any of your questions. So we have a couple questions so far. The first one is for Caitlin. Caitlin, is it possible to have more than one type of capitated managed care? So, for example, can a state have both a PACE program and DSNPs?
Yeah, great question. It is possible to have more than one type of capitated managed care. I mean, which type the state chooses really just is going to depend on what works best for them and their dually eligible beneficiary population, what makes the most sense, for their existing Medicaid landscape. But, for example, it is possible for a state to have a PACE program and a DSNP program, or MMPs and a PACE program.
Great, thank you so much. The next one is for Giselle. So why are qualified Medicare beneficiaries the only category of dually eligible individuals that are eligible for a Part A buy-in?
Yeah, so QMBs are the main category of dually eligible individuals for which the state is responsible for paying those Part A premiums. The state doesn't hold that responsibility for specified low-income beneficiaries, or SLMBs, or qualifying individuals, also known as QIs. While states do cover Part A premiums for qualifying disabled and working individuals, or QDWIs, those premiums are paid through a separate process. So QDWIs are not included in Part A buy-in, just for the QMBs.
Got it, great, thank you. And just a reminder to the attendees to feel free to put in any of your questions in the Q&A icon chat feature. We do have another one, again, going back to Caitlin. Can you clarify what it means when you said that there can't be any duplication between supplemental benefits and existing Medicaid benefits, but that supplemental benefits can expand upon existing Medicaid benefits?
Yeah, so that is a little tricky. So let's go through that a little bit. A DSNP can only offer supplemental benefits for optional services that are also covered by Medicaid, as long as the supplemental benefits offered expand and don't duplicate what's already being offered by Medicaid. So, as an example, if a state Medicaid program only covers, say, emergency dental care for adults, a DSNP could use supplemental benefits to enhance the dental coverage to be more comprehensive and include things like dentures, oral surgery, periodontal care, and so on.
Got it. Thank you. All right. This one I think is also for you, Caitlin. What's the difference between a DSNP that's being designated as a FIDE SNP versus a HIDE SNP?
Yeah. So, to be considered a HIDE SNP, a plan has to provide either directly or through a companion Medicaid managed care plan, either LTSS or behavioral health services, as well as other Medicaid services to a dual eligible population. But those benefits, may be covered by two separate plans owned by the same parent company, a DSNP and, say, an affiliated Medicaid managed care plan, for example. So in contrast, a FIDE SNP must provide Medicaid LTSS and may also provide behavioral health services, but the services must all be covered by the same legal entity. And I should also say that FIDE SNP also coordinates the delivery of Medicare and Medicaid services using aligned care management and specialty care network methods for high-risk beneficiaries. And they also employ policies and procedures approved by CMS and the state to coordinate or integrate beneficiary communication materials, enrollment, communications, grievances and appeals, and quality improvement.
Great, thank you. That's really helpful. The next question is about crossover claims. So I'm going to give this to Giselle. Giselle, what would be an alternative method for states that choose to not use the automated crossover claims, and what would be the benefit of that?
Yeah, that's a great question. So an example of an alternative process would be having the state forward crossover claims to the appropriate health plan rather than just having it done automatically. Some states do find that this enables them to kind of ensure that the health plans receive only the claims for which they're responsible for in situations when an enrollee is in more than one plan, or if they're in fee-for-service for different benefits, or where the enrollee has changed plans. But just to reiterate an earlier point, automatic crossover claims processes are particularly beneficial when the state is simultaneously working with DSNPs and Medicaid managed care plans to cover care for dually eligible individuals. Great, thank you. One more question for you, Giselle, about lesser of policies. How many states work around any potential consequences related to access of care when the lesser of policy is being used? Yeah, no, that's a real concern. So one way is for states to request or require DSNPs to use their Medicare Advantage supplemental benefits to cover cost sharing for services. So since DSNPs are able to negotiate their own rates with providers, covering cost sharing for certain services through their supplemental benefits can help reduce or completely eliminate the negative impact that lesser of policies may have on the provider access and access to care that dually eligible individuals may face. Great, thank you. So another question, I think this one might be for Erin. Are there any feasibility studies that explore the states themselves providing the integrated care options to clients opposed to private health insurance companies administrating this benefit?
That's a really good question. We're not aware of any feasibility studies. That doesn't mean that there aren't states that have conducted those. Those kinds of studies don't tend to be made public unless or until a particular state chooses to move forward with an option. It's relatively common for state agencies to do feasibility studies, the results of which remain completely internal to that state agency. So those of us that are outside of state government wouldn't necessarily be privy to that information if there were states that were looking into options of administering integrated care benefits outside of private health insurance companies. That said, I definitely want to be sure to point out a couple of things about the existing integrated care programs. First of all, the state of Washington has a managed fee-for-service financial alignment initiative demonstration, which does not involve private health insurance companies. It involves the state and care management contractors and the delivery of care management to individuals who remain in a fee-for-service Medicaid system. And we have a issue brief about that initiative on our website. If you search for Washington demonstration on the ICRC website, you ought to be able to find that issue brief to learn more about what they've done. And I believe that Caitlin mentioned already that CMS has welcomed states to submit applications not only for capitated model demonstrations, but also for fee-for-service ones, like what the state of Washington has done, or for state-specific models. So that's all important to remember. States do have those options. Private health insurance companies are not the only entities that can administer these benefits. And it's also important to point out that there are states who have not only local insurance coverage plans in their demonstrations and among their DSNPs, but also in some cases nonprofit organizations as well. So depending on the state, there are a wide range of entities that serve as Medicare, Medicaid plans and as DSNPs already, but there are certainly a vast array of options and opportunities available to states moving forward as well.
Great, thanks, Erin. Another question here, are there any resources available on how to get a provider added to the reports or files so that their claims cross over to state Medicaid agencies?
So
Erin,
I can take this one too, Danielle, and others can jump in if they want to add to it. I think that this would depend, the process of making sure that a provider's claims properly get crossed over from the Medicare entity to the Medicaid entity depend on who's providing the Medicare and the Medicaid coverage. So in fee-for-service systems where Medicare, if a beneficiary is receiving their Medicare benefits through fee-for-service Medicare and they're receiving Medicaid benefits through fee-for-service Medicaid, so the person is fee-for-service on both sides. Medicare does have systems already set up such that if that provider is enrolled as a Medicare provider and is enrolled with the state as a Medicaid provider, fee-for-service Medicare will already cross over those claims to state Medicaid agencies as long as the beneficiary is identifiable as a dually eligible beneficiary. The trick comes in when an individual is enrolled in managed care systems on either the Medicare side, the Medicaid side, or both. So for example, if a Medicare Advantage plan, if a beneficiary is enrolled in a Medicare Advantage plan for their Medicare coverage, those claims will not necessarily cross over directly to the state unless the state actually works out a system of automatic crossover with those Medicare Advantage plans. So that's something that the state has to work out with the Medicare Advantage plans, whether they be DSNPs or not, if the state wants to get those automatic crossovers from the Medicare Advantage plan. The same is true on the Medicaid side. If there's managed care on the Medicaid side, those Medicare claims don't automatically go to Medicaid managed care companies unless the state actively sets up a system by which that can happen. And states can work with CMS, they can work with their managed care plans on both the Medicare and Medicaid side to set up those systems. And that's one of the recommendations that we were making in these slides, is for states to actively work with those plans on getting those crossover systems set up so that if somebody is in managed care on either the Medicare side, the Medicaid side, or both, they can, in fact, still have that crossover be automatic.
Thank you so much, Erin. I know we have a couple other questions, but we are out of time. For those of you that have questions, if you can email the ICRC inbox, we'd be happy to respond to those, or just send us a note in the chat with your email address, and we can get back to you. But just want to wrap up and thank you all. Thank you again to all of our presenters. If you would like to revisit today's conversation and the slides, a recording of this call and the presentation will be uploaded to the ICRC website. I urge you all to revisit the website where you can find links to past study hall calls, webinars, briefs, and also to submit technical assistance requests. We hope that this has been valuable for you all today. And if you are logged into Zoom, please complete the survey that will appear at the end of the webinar. We look forward to reviewing your feedback and will make any changes for future webinars. The survey will also be sent out by email with the recording after the webinar today. Thank you so much again to our presenters, to our partners at CMS, and to all of you for joining us today. Thank you.